Welcome to
Cardiology
Success
MCQs 11.
MRCP MCQs.
A 35-year-old man presents with a blood pressure that is higher by 25 mm of mercury when measured in his left arm compared with that in his right arm. At a school physical examination, such a difference in blood pressure was noted for the first time. Routine findings of blood tests. Liver function tests. Thyroid tests and biochemistry are normal. He also has a systolic murmur at the right upper sternal border. What fits best as a diagnosis? 1. Takayasu's vasculitis. 2. Aortic stenosis supravalvular. 3. Subclavian stele. 4. Aortic aneurysm. 5. Occlusive disease of the arteries. Answer. Aortic stenosis supravalvular. Update. In supravalvular aortic stenosis, the blood is directed up the brachiocephalic artery preferentially. There will be an aortic stenosis murmur or carotid pulsation. Other findings might include a difference in carotid pulsation or the murmur of aortic stenosis. There is a similarity of presentation to coarctation of the aorta. In coarctation, the narrowing is beyond the origin of the left subclavian artery. There are also found hypertension in the arms and weak femoral pulses as the classic features of coarctation of aorta. In vasculitis, ESR and C-reactive protein is also raised. There will be anemia. Also, arterial occlusive disease is incorrect. The term arterial occlusive disease is slightly unusual. There is no suggestion of coronary artery disease, no signs of angina or significant history. In addition, coronary atherosclerosis would not account for the dichotomous readings of blood pressure. Artifact due to lack of simultaneous recording. 886 rate this question. Artifact due to lack of simultaneous recording is incorrect. A difference of 30 mm of mercury is large, clinically significant, and must be investigated. There is no suggestion that the recordings may be inaccurate. Subclavian stele syndrome is incorrect. Normally there is blood flows from the aorta into the subclavian artery, and then to the vertebral artery to supply the brain. In subclavian stele syndrome, less blood flows through the subclavian artery. Then the blood has to flow up in one of the other arterial branches to the brain through vertebral arteries or carotid arteries, and then the basilar artery. It enters the cerebral arterial circle and then the contralateral vertebral artery to the blocked subclavian. It then enters into the distal subclavian artery supplying the upper limb. It leads to decreased blood flow in one arm. There is also a history of faints, neurological issues and memory problems to be significantly present. MCQ 12. A man's wife noted prior to his 45th birthday that he is complaining of chest pain which attacks him in the early hours at dawn. He was thoroughly investigated for his symptoms and angiography was also done, but no investigation showed any sign of ischemic coronaries. His lipid profile is within normal range and he does not smoke. What will be the treatment of choice at this stage of investigation? 1. Clopidogrel. 2. Propranolol. 3. Lorazepam. 4. Atenolol. 5. Isorbide mononitrate. Answer. Isorbide mononitrate. Update. The most appropriate diagnosis here is coronary artery vasospasm. That present with angina-like chest pain at rest. Specifically in the early morning hours, the diagnostic findings on echocardiography, ETT and angiography are within normal limits. Coronary artery spasm is inducible on angiography in some cases. Nitrates and calcium channel antagonists are the treatment of choice for coronary artery spasm. Clopidogrel is incorrect. Coronary artery spasm is not due to the blockage of coronary arteries and there is no formation of blood clots. Hence clopidogrel is not a recommended option. Propranolol is incorrect. Beta blockers are helpful, but it is being asked this is for the agent that will best manage angina symptoms. Hence, a vasodilator is a preferable option over a beta blocker, which will not necessarily improve symptoms, but may improve long-term outcomes. Lorazepam is incorrect. Benzodiazepines would not be useful in this case. Atenolol is incorrect. In options there are two very similar beta blockers. It should lead us that beta blockers are not the correct choice. MCQ 13. A girl with right ventricular cardiomyopathy that was diagnosed 2 years ago when she was 27 years old. She was without any problem till now when she suffered from palpitations after playing basketball. On EKG it sustained monomorphic ventricular tachycardia. She is otherwise healthy and normal with normal EKG also. How to start the treatment as a first line? 1. Dual chamber pacemaker. 2. Sotalol. 3. Catheter ablation. 4. Single chamber pacemaker. 5. Implantable cardioverter defibrillator, ICD. Answer. Sotalol. Updates. It is a case of sustained ventricular tachycardia. In clinical trials sotalol has shown the highest efficacy. Hence sotalol the choice of recommendation for the prevention of recurrence of ventricular tachycardia. Note that you have been asked to give the best first-line treatment. Implantable cardioverter defibrillator, ICD. Radiofrequency catheter ablation and rate responsive. Dual chamber pacemaker and single chamber pacemaker are not be first-line treatment. In certain cases, notably the cardiac arrhythmia suppression trial, flecainide has been shown to increase mortality if used to suppress ventricular extrasystoles in the setting of acute myocardial infarction. ICD is incorrect because this is not first-line treatment. The decision to cite an ICD would need to be considered carefully because there are risks and benefits. ICD therapy might reduce mortality in patients with aborted sudden cardiac death and in high-risk patients with ventricular tachycardia and compromised right and left ventricular function. However, there are problems with using an ICD in right ventricular cardiomyopathy, in which the mass of right ventricular muscle might be too thin, such as low R-wave amplitude, high thresholds or lead perforation. Radiofrequency catheter ablation is incorrect. Radiofrequency catheter ablation is indicated for medically refractory ventricular tachycardia in selected patients only. Information regarding its efficacy in preventing sudden cardiac death is lacking. It is not possible to jump from the scenario provided to radiofrequency catheter ablation. The mechanism for ventricular tachycardia arrest does not sound related to accessory or pre-excitatory pathways. It is more likely to be related to a diseased right ventricle. Rate responsive. Dual-chamber pacemaker is incorrect. A rate-responsive dual-chamber pacemaker would be indicated for cardiac failure with left and right ventricular desynchrony. Not for right ventricular failure and ventricular tachycardia arrest. MCQ 14. A 16-year-old man had a cardiac arrest while playing football and was resuscitated. He recovered fully and was later found to have hypertrophic obstructive cardiomyopathy, HOCM. What is the best strategy for him? 1. Amiodarone. 2. Implantable cardioverter defibrillator, ICD. 3. Amlodipine. 4. Atenolol. 5. Dual-chamber pacemaker. Answer. Implantable cardioverter defibrillator, ICD. Updates. Implantable cardioverter defibrillator, ICD, is the most beneficial for the secondary prevention of sudden cardiac death, SCD, in patients with HOCM based on evidence and general agreement. Amiodarone is incorrect. In the primary prevention of SCD in HOCM, amiodarone may have a role in some patients. Based on the general consensus is secondary prevention via an ICD as the preferred option. Atenolol is incorrect. Beta blockers aid HOCM management because they can slow down the heart rate and reduce the likelihood of ectopic beats. However, this strategy should be followed after the patient has been treated correctly with an ICD in the acute setting. Amlodipine is incorrect. Verapamil aids HOCM management because it can slow down the heart rate and reduce the likelihood of ectopic beats. That said, for patients who cannot tolerate beta blockers or do not have good control of symptoms with beta blockers, non-dihydropyridine calcium channel blockers such as verapamil can be used. However, non-dihydropyridine calcium channel blockers are potentially harmful in patients in a setting systemic hypertension or severe dyspnea at rest. These medications also reduce the heart rate, though their use in patients with severe outflow obstruction, elevated pulmonary artery wedge pressure, and low blood pressures should be followed with consultations. Rate responsive. Dual-chamber pacemaker is incorrect. Rate responsive. Biventricular pacing will not help reduce the risk of cardiac arrest and will not have a useful impact in cardiac arrest because this type of device does not have a defibrillator function. MCQ 15. A patient has tuboeruptive xanthomas as characterized by red papules and nodules that appear inflamed and tend to coalesce. Distributed subcutaneously and mainly on the extensor surface of the extremities. Lipid profile testing showed increased levels of total cholesterol and triglyceride. and decreased levels of high-density lipoprotein. Which diagnosis fits the best? 1. Type 1 hyperlipidemia. 2. Type 2 hyperlipidemia. 3. Type 3 hyperlipidemia. 4. Type 4 hyperlipidemia. 5. Type 5 hyperlipidemia. Answer. Type 3 hyperlipidemia. Updates. In type II hyperlipidemia there are lipid accumulations. Tuboeruptive xanthomas occur, which is due to high numbers of chylomicrons and high levels of intermediate density lipoprotein. The most common cause for this form is the apolipoprotein E2 genotype. Type 3 hyperlipoproteinemia is due to cholesterol-rich, very low-density lipoprotein, VLDL. Its incidence has been estimated to be almost equals 1 per 10,000 individuals. It is associated with hypercholesterolemia, typically 8 to 12 mol/L. Hypertriglyceridemia, typically 5 to 20 mol/L. A normal concentration of apolipoprotein B. And 2 types of skin signs like palmar xanthomata or orange discoloration of skin creases, tuberoeruptive xanthomata on elbows and knees. It is characterized by the early onset of cardiovascular disease and peripheral vascular disease. Type I hyperlipidemia is incorrect. Type I hyperlipoproteinemia, hyperchylomicronemia, is associated with eruptive xanthomas. Complications include occlusion of the retinal vein, acute pancreatitis, steatosis, organomegaly and lipemia retinalis. Type II hyperlipidemia is incorrect. Type II hyperlipoproteinemia is associated with xanthoma tendinosum, nodular swellings of tendons. Type II hyperlipoproteinemia, by far the most common form, is classified further into types IA and IB depending mainly on whether the increases in triglyceride levels occur in addition to those of low-density lipoprotein cholesterol. Type IV hyperlipidemia is incorrect. Type IV hyperlipoproteinemia is associated with eruptive xanthomas. Type V hyperlipoproteinemia is incorrect. Type V hyperlipoproteinemia, mixed hyperlipoproteinemia familial or mixed hyperlipidemia, is very similar to type I, but with high levels of VLDL in addition to many chylomicrons. It is also associated with glucose intolerance and hyperuricemia. MCQ 16. A 51-year-old lady underwent cardiac catheterization procedure to take her parameters of pulmonary hypertension because she presented with syncope and increasing shortness of breath. The wedge pressure was normal and the mean mitral valve diastolic pressure gradient was greater than 3 mm of mercury at rest, both of which increased with movements. What diagnosis fits the best? 1. Mitral stenosis. 2. Left ventricular diastolic dysfunction. 3. Pulmonary stenosis. 4. Mitral regurgitation. 5. Ventricular Ventricular septal defect. Answers. Updates. The diastolic pressure in the left atrium is increased at rest and during movements, suggesting reduced flow through the mitral valve, as you might expect in mitral stenosis. The hemodynamic pattern is typical of mitral stenosis and may also be seen in cor triatriatum, in which there is a left atrial membrane. Left ventricular diastolic dysfunction is incorrect. In left ventricular diastolic dysfunction, the left ventricular end diastolic pressure is greater than 15 mm of mercury. Pulmonary stenosis is incorrect. Major occlusion of pulmonary arteries by a clot or tumor is associated with a focal pressure gradient in a lobar or larger pulmonary artery. Intravascular filling defect or narrowing. Mitral regurgitation is incorrect. A large systolic pressure wave in wedge tracing can be seen in patients with mitral regurgitation. In addition, regurgitation of contrast to the left atrium can be seen from a left ventricular angiogram. Ventricular septal defect is incorrect. In congenital heart disease, there will be an increase in oxygen saturation in the right heart and reduction in the left heart. MCQ 17. A young man is being investigated for palpitations. His pulse and respiration are normal. On cardiovascular examination, there is a systolic murmur in the second left intercostal space. Precordial pulsations and impulse were also noted. In family history, there is a sudden death of his father at an early age of 40 years while running after a deer during hunting. What is the best diagnosis in this case? 1. Prolapse of the mitral valve. 2. Atrial septal defect. 3. Aortic stenosis. 4. Hypertrophic cardiomyopathy. 5. Aortic regurgitation. Answer. Hypertrophic cardiomyopathy. Update. This is a common presentation of hypertrophic cardiomyopathy with a history of sudden death in the family upon exertion. It is usually due to a mutation in one of 9 sarcomeric genes, which results in a mutated protein in the sarcomere, the primary component of the myocyte. These are predominantly single-point missense mutations in the genes for B-myosin heavy chain, myosin-binding protein C, cardiac troponin T, or tropomyosin. These mutations cause structural abnormalities and possible deficiencies in force generation in myofibrils and myocytes. Hypertrophic cardiomyopathy appears in all ethnic groups, and its prevalence in the general population is almost equals 0. 2 to 0. 5%. Mitral valve prolapse is incorrect. Mitral valve prolapse is characterized by a mid-systolic click, followed by a late systolic murmur heard best at the apex. Atrial septal defect is incorrect. An atrial septal defect would present with a prominent left precordium with an ejection murmur in the second left intercostal space. Aortic stenosis is incorrect. The patient is young and otherwise healthy. It is incredibly unlikely that this patient would have calcific aortic stenosis. He could have a bicuspid valve that has deteriorated rapidly. But the mid to late systolic impulse in the precordial motion, triple ripple, is specific for hypertrophic cardiomyopathy. Aortic regurgitation is incorrect. Mixed aortic valve disease would present with murmurs associated with aortic stenosis, systolic. Crescendo, decrescendo murmur is heard loudest at the upper right sternal border. At the second right intercostal space and radiates to the carotid arteries bilaterally, and aortic regurgitation, early diastolic and decrescendo, which is best heard in the third left intercostal space and may radiate along the left sternal border. Either of these murmurs can predominate. MCQ 18. A 25-year-old woman is seen in the outpatients department and found to have a loud first heart sound, an early diastole sound, followed by a mid-diastolic murmur. She tells you that when she was a child, she had a nonspecific illness which her doctor at the time thought may be rheumatic fever, but which was never proven by biochemical testing. What is your best diagnosis? 1. Mitral valve prolapse. 2. Atrial fibrillation. 3. Fourth heart sound. 4. Mitral stenosis with mobile leaflets. 5. Mitral valve prolapse. Update. There is a loud first heart sound and, if an opening snap is heard, this indicates that the mitral valve is mobile leaflets. The snap occurs if the superior systolic bowing of the anterior mitral valve leaflet is reversed rapidly towards the left ventricle in early diastole, owing to the high left atrial pressure. Mitral stenosis with a fourth heart sound is incorrect. There is no mention of a fourth heart sound. The latter is often associated with filling of a stiff left ventricle. This can be seen in left ventricular hypertrophy, amyloid, hypertrophic cardiomyopathy, or scarred fibrosed left ventricle due to ischemia. The fourth heart sound is classically late diastolic or presystolic. It occurs if augmented atrial contraction causes presystolic ventricular distension so that the ventricle contracts with greater force. Atrial fibrillation is incorrect. There is mention of an irregular pulse, atrial fibrillation. Atrial fibrillation often is associated with a variable first heart sound. Pulmonary hypertension is associated with an accentuated pulmonary component of the second heart sound. A right ventricular third heart sound. And parasternal heave indicating a hypertrophied left atrium. Mitral valve prolapse is incorrect. Mitral valve prolapse is associated with a mid-systolic click followed by a late systolic murmur heard best at the apex. Important associations to be aware of. 1. Soft first heart sound, S1. Immobile mitral stenosis. Hypodynamic state. Mitral regurgitation. Long PR interval. 2. Split S1. Right bundle branch block. Left bundle branch block. Ventricular tachycardia. Epstein's anomaly. 3. Variable S1. Atrial fibrillation. Complete heart block. 4. Loud S2. Hypertension. Tachycardia. Atrial septal defect. 5. Soft absent S2. Severe aortic stenosis. 6. Fixed splitting S2. Atrial septal defect. 7. Wide split S2. Right bundle branch block. Pulmonary stenosis. Mitral regurgitation. 8. Single S2. Severe pulmonary stenosis. Aortic stenosis. Hypertension. Ventricular septal defect. Tetralogy of Fallot. Eisenmenger's syndrome. 9. Reversed split S2. Left bundle branch block. Right ventricular pacing. Patent ductus arteriosus. Aortic stenosis. 10. S3. Rapid left ventricular filling, mitral regurgitation. Ventricular septal defect. Can be normal in children. 11. S4. Filling of stiff left ventricle, left ventricular hypertrophy. Amyloid. Hypertrophic cardiomyopathy. Ischemia. MCQ 19. A man in the early 50s had a triple vessel disease and was treated with coronary artery bypass grafting last week. He has a rise in both the direct and indirect bilirubin tests. Other biochemistry tests are normal. What is the most logical explanation? 1. Anesthetic damage. 2. Liver failure. 3. Right-sided failure. 4. Left-sided failure. 5. Cardiopulmonary bypass surgery-induced hemolysis. Answer. Cardiopulmonary bypass surgery-induced hemolysis. Update. Raised levels of direct and indirect bilirubin. With no other changes in liver function tests. Indicates hemolysis on cardiopulmonary bypass. This can be confirmed by demonstration of increased levels of free hemoglobin in plasma. There is no specific treatment for hemolysis on cardiopulmonary bypass. Anesthetic-induced damage is incorrect. In a patient with no underlying liver disease, which we have no evidence of, anesthesia is unlikely to cause an increase in bilirubin levels alone. Liver failure is incorrect. Shock liver syndrome is also known as ischemic hepatitis and is due to acute hypoperfusion leading to diffuse hepatic injury. Markedly increased levels of enzymes are seen. This patient had no change in levels of aminotransferases, so this diagnosis is unlikely. Treatment is aimed at maximizing cardiac output and oxygenation. Right heart failure is incorrect. Right heart failure is a possible cause of hyperbilirubinemia in the immediate period after cardiopulmonary bypass. However, in this case, there was no increase in the level of alkaline phosphatase, which you would also expect. Left-sided heart failure alone usually does not present as isolated rise in bilirubin. MCQ 20. MCQ 20. A 30-year-old girl who wishes to join the competitive sports proceeds for a general medical examination. Her healthcare provider arranges for a series of physical examination, a chest X-ray and an EKG. What is the indication of a permanent pacemaker in this patient? 1. First-degree block at the AV node. 2. First-degree block with an HV interval less than 100 milliseconds. 3. Second-degree type I AV block. 4. Right bundle branch block. 5. Second-degree type 2 AV block. Answer. Second-degree block at the distal conduction system. Update. In asymptomatic patients, a ppm is indicated in a second-degree type 2 AV block or third, complete, heart block. A second-degree type 2 AV block indicates disease at the distal conduction system rather than the AV node, which gives a second-degree heart type I, Wenckebach, block. First-degree block at the atrioventricular, AV, node is incorrect. A ppm is not indicated in a first-degree block at the AV node. First-degree block in the distal conduction system with an HV interval less than 100 milliseconds is incorrect. A ppm is indicated only for cases of first-degree AV block in the distal conduction system, in which a HV interval greater than 100 milliseconds is associated with symptoms. Second-degree block at the AV node is incorrect. A second-degree type I AV block indicates disease at the AV node, Wenckebach. In patients with a second-degree type I AV block, pacing should be considered if the patient is symptomatic, or if the pathology is located intra or infra to the bundle of his after electrophysiologic studies. These are not routinely done. However, right bundle branch block is incorrect. A ppm is not indicated for bundle branch block if asymptomatic because only 1 to 2% of patients will develop an AV block and cardiac pacing has not been shown to reduce mortality.
Thanks for listening. Come age to visit us. Thanks for listening. Come age to visit us.